السلام عليكم. إن شاء الله هنتكلم عن history taking and clinical examination. In this lecture we start with history taking. In obstetric history, this is the general form of any medical history taking. Starts with personal history, history of present illness, obstetric history in a form of current pregnancy and past obstetric history, then gyne history, past medical history, past surgical history, drug history, family, social, and immunization history. And in the last, we'll present this information in a summary. First of all, greet the patient, confirmed identity, introduce yourself, explain your role, and take permission in a form of verbal consent. Make sure patient comfortable. Ensure you are sitting at the same level of the patient and maintain eye contact. Personal data, as you know, name of the mother or husband for identification, age, as the age is the main risk factor for many conditions, resident, origin and tribe, education level and occupation, marital status and duration, consanguinity, religion. Ask about religion, as there is some beliefs. Religious beliefs can affect management. For example, Jehovah's Witness, which is the members of Christian group, not allow blood transfusion. Mother blood group, and if rhesus negative, ask about father blood group. If the mother is rhesus negative and father is confirmed to be rhesus positive, this difference between father and mother rhesus, called rhesus incompatibility, will result in fetal and neonatal hemorrhagic disease. Is the patient admitted in a hospital? Ask about date and reason for admission. History of present illness. Ask about the complaint. Record in a patient words. Ask about duration. Analyze each complaint chronologically. Mention any investigation done, any intervention, surgical or medical, and review symptoms of the affected system. After that, stomach review. This is the main part of this lecture of obstetric history in a form of history of current pregnancy and past obstetric history. In history of current pregnancy, we need to know the part of the patient, last menstrual period to calculate expected date and gestational age, and then each trimester symptoms will be analyzed. Gravida and parity. Gravida denotes the pregnant state, both present and past, irrespective of period of gestation. Other definition, it's a number of pregnancies including the current one. Never say gravida X unless the mother is now pregnant. Parity is any pregnancy continue beyond the period of viability, which is 24 weeks of gestation. Type. The terminology used is gravida X, para A plus B. X is the total number of pregnancies, including this one, regardless of duration of pregnancy. Is the total number of pregnancies, تمام? Regardless of outcome. Bara A is the number of births beyond 24 weeks of gestation, beyond the viability. Plus B is any pregnancy terminated before 24 weeks of gestation, can include ectopic pregnancies, miscarriages, and molar or gestation trophoblastic disease. Any pregnancy terminated before viability. For example, woman who is pregnant for the first time, so it's gravida 4 صح, with one normal delivery at term, one termination at 9 weeks, and one miscarriage at 16 weeks. The patient is gravida 4, bara 1, which is a term delivery, plus 2, which is a one termination at 9 weeks and one at 16 weeks, both below 24 weeks. So the patient is gravida 4, bara 1 plus 2, has 2 losses before viability. Expected date of delivery can be calculated from the last menstrual period date using Naegele's rule. Has 2 forms, either adding 9 calendar months and 7 days to the first day of the last menstrual period, or add 1 year, 7 days and subtract 3 months. The last use is the last menstrual period from April to December. We add 1 year. If the last menstrual period from January to the March, no need to add 1 year, only add 9 calendar months. تمام؟ For example, the easiest one, the patient had her first day of last menstrual period on 1st January. As Nagel's rule, we add 9 calendar months and 7 days to the LMB, which is the last menstrual period, صح? By adding 9 calendar months to January, it comes 1st of October. Then add 7 days to be 8th of October, which is the expected date of delivery. Simple, this is the Nagel's rule to calculate expected date of delivery. Another example is the first day of LMB is the 5th of April 2024. The Nagel's rule to add 1 year, subtract 3 months and add 7 days, صح? By adding 7 days will be 12th of January 2025. So we can calculate expected date of delivery if the patient sure of her date and know her last menstrual period by Nagel's rule. Other method to calculate expected date by date in scan, which is ultrasound between 8th and 13th weeks of pregnancy, with a more reliable than LMB. This is the Nagel's rule. Begin on the first day of the last menstrual period, subtract 3 months, add 7 days and add 1 year. In a Hijri calendar, we add 14 days and subtract 3 months. In Gregorian calendar, we add 7 days and subtract 3 months. If the pregnancy was induced by IVF, in vitro fertilization, the date of embryo transfer, subtract 7 days and add 9 months. And to calculate expected date from date of single coitus, add 265 days. All these methods to calculate expected date, only we interested in Nagel's rule. Forget about others. If the patient uncertain of her date and doesn't know her last menstrual period date, can calculate expected date as we say from early ultrasound scan, it is dated scan, or by date of quickening. Quickening is the first appreciation of fetal movement by mother in primary gravidas, usually around 18 to 20 weeks of gestation, and multiparous between 16 to 18 weeks of gestation. So we can know the LMB by subtract 20 weeks from date of quickening in primary gravidas and subtract 18 weeks from date of quickening in multiparous patient. The last method to calculate expected date by clinical examination will be discussed in the next lecture. But the most accurate one is the date in scan. In a summary, can calculate expected date of delivery by LMB using Nagel's rule. If uncertain of her date, other options is the date in scan, date of quickening, and clinical examination. Nagel's rule has two forms, either add 7 days and 9 calendar months, or add 1 year and 7 days, then subtract 3 months. The next important concept to know is the gestational age. Gestational age is a universal standard used by obstetrician and neonatologists for discussing fetal maturation. Why it's important to calculate gestation age? Gestation age guide timing of fetal screening and prenatal diagnostic tested. Also, it can optimize fetal growth surveillance, so it aids in planning pregnancy and timing of delivery, preventing prematurity, which is delivery for 37 weeks, and post-date, which is pregnancy more than 40 weeks. Gestation age calculated from first day of menstrual period. As we know, ovulation and conception occur at the middle of menstrual cycle. In a patient with regular 28 days menstrual cycle, ovulation occurs around day 14 with the middle of menstrual cycle. Thus, gestation age is counted begin approximately 2 weeks before conception, as it calculated from day 1, which is the first day of menstrual cycle. Other concepts with the embryologic age differ from gestation age, which is calculated from date of conception to date of delivery. Date of conception which occur at the middle of cycle, so typically there is 2 weeks difference between gestation age and embryologic age. In obstetric history, we calculate and use gestation age, not embryologic age. Gestation age is measured in weeks, usually by calculating time difference between first day of menstrual cycle and the current date. تمام؟ To calculate gestation age, either subtract current date from the first day of LMB, which is the easiest one, especially in the first and second trimester. If the patient in her third trimester or near term, can calculate gestation age from expected date of delivery in 2 steps. This will be explained in an examples. تمام? But first we have to know the full pregnancy period lasts for 280 days or 40 weeks or 9 months plus 1 week. Divided into 3 trimesters, each trimester equals to 13 weeks. In reality, a typical month is 30 or 31 days except of February, which has 28 to 29 days. This means a month equal to 4 weeks and 3 days, not exactly 4 weeks. These facts will aid in calculation of gestational age. The most important to know, each month of 30 days equal to 40 weeks plus 2 days, and each month of 31 days equals to 4 weeks plus 3 days. As gestation age calculated in weeks, we have to know full pregnancy period is 40 weeks. Each trimester, which is 3 months, is equal to 13 weeks, and each month equals to 4 weeks plus 3 days if that month was 31 days, and 4 weeks plus 2 days if this month is 30 days. تمام? We have to convert these days and months in weeks. Is it clear? Example on gestation age calculation. First day of LMB was 4th day of January 2025. Expected date using Needles rule by adding 7 days and 9 calendar months will be 11th of October of the same year. To calculate gestation age with the difference between first day of LMB and current date, which is 26th of April 2025. This is the current date. تمام? As the patient in her second trimester, it's easiest to calculate from the current date and LMB rather than calculating gestation age from expected date of delivery. From this point, we have 2 choices. Either submit the remaining days in each month and divide it by 7 to convert it into weeks, or convert every individual month into weeks, then submit this number of weeks and days to reach gestation age. Other example, if today is 18th of January and LMB was 5th of December, the duration between these 2 dates is 44 days. Dividing 44 days by 7, The gestation age is 6 weeks plus 2 days. I wish it's clear for you. It needs some practice to be easy. As a continuation of obstetric history, there is a certain question related to each trimester. In the first trimester, ask about pregnancy. Is it spontaneous or induced? How patient diagnose her pregnancy and confirmation method. Ultrasound scan, if done, the timing. Findings of ultrasound scan in a form of localization of pregnancy, intrauterine or extrauterine, number of fetus, single or multiple pregnancy, viability, and calculation of expected date. Especially if it's date in a scan between 8 and 13 weeks, it's the most accurate calculation of expected date. Is it correspond to her date by LMB or not? Ask about pregnancy symptoms, nausea and vomiting or morning sickness, folic acid supplementation, which should be pre-conception, before pregnancy, 3 months, and in the first trimester at least. Any vaginal bleeding asked in each trimester, first, second, and third trimester. In each trimester, ask about vaginal bleeding. Radiation exposure, fever, and skin rash. If the patient in her second trimester, ask about quickening, which is the first appreciation of fetal movement by mother. In primary gravity is late between 18 to 20 weeks of gestation. In multiparous, between 16 and 18 weeks of gestation. Vaccination and dose number. Vaccination in pregnancy male tetanus toxoid vaccine, which is have 5 doses in a total. Iron supplementation. Folic acid in first trimester, iron and calcium supplementation from second trimester and up to postpartum period for lactation. Vaginal bleeding, UTI symptoms, detailed anomaly scan. Anomaly scan is ultrasound done in second trimester between 18 and 22 weeks of gestation for any fetal structural anomaly. Third trimester, if the patient still appreciates fetal movement, any vaginal bleeding, UTI symptoms, iron supplementation, any drain flicker or anemia symptoms. After current pregnancy history, ask about past obstetric history. Details of all previous pregnancies, including miscarriage and termination. Mode of termination, either before viability, medical and surgical termination, and after viability is delivery either vaginal or by cesarean section. Date and place of delivery, onset of labor, either induced or spontaneous onset of labor. If induced labor, ask about details of induction. Offspring or outcome, ask about weight, gender, and condition at birth. Any complication at puerperium or post-abortive period. Time of last delivery. History often repeats itself, so previous antenatal, intrapartum, or postpartum complications should influence management of this pregnancy. If the patient has miscarriage, ask about gestation age or months at which miscarriage occurred, how it's managed, can be managed medical or surgical, if patient received blood transfusion or anti-D if risk is negative. In stillbirth, which is intrauterine fetal death after viability or after 24 weeks, ask if it's macerated or fresh stillbirth. Fresh stillbirth, which is occur less than 24 hours from delivery. Macerated stillbirth, it's old stillbirth more than 24 hours from incident to delivery. Any congenital malformation, if patient admitted to the nursery, ask about cause and duration of admission. Early neonatal death, ask about cause of death. Following obstetric history, there is a gynecological history. Starting with menstrual history, menarche is the age at first menstrual cycle. between 11 to 16 years, and the mean number of bleeding days over the duration of menstrual cycle. If the patient bleeds for 5 days every 28 days, so it will be 5 over 28 days. Regularity and amount. Is it regular or irregular menstrual cycle? Amount. Is it average or heavy menstrual bleeding? Associated symptoms. Dysmenorrhea. It's a painful menstrual cycle. Dyspareunia is painful sexual intercourse. Intermenstrual bleeding is an irregular vaginal bleeding in between expected menstrual cycles. Postcoital bleeding is any vaginal bleeding post-sexual intercourse. Ask about previous gynecological procedures. Gyne procedures example D&C, dilatation and curettage, ovarian cystectomy, myomectomy, endometrial biopsy or cervical biopsy. These are examples. Cervical smear history. This is screening for cervical cancer. Ask about date of last smear and the result. Induction of ovulation or history of subfertility. Contraception. Ask about methods of contraception used, duration of use, any side effect and cause of discontinuation. Sexual history. Ask about dyspareunia. As we say, it's a painful sexual intercourse. Any history of sexually transmitted infection or pelvic inflammatory disease. Abnormal vaginal discharge. There is a normal vaginal discharge, which is a clear mucoid around ovulation and before menstruation. If any vaginal discharge, ask about odor, color, and any associated itching. History of gyne problems, especially fibroids, polycystic ovaries, endometriosis, and subfertility history. This is a gyne history. Menstrual, contraception, sexual history, any gyne procedures or gyne condition, cervical smear history, history of subfertility or induction of ovulation. Following that, there is a general form of history taken in a medical school, including past medical history, past surgical history, family history, socioeconomic, and drug history. By the end of history taken, you have to summarize this information in a form of positive findings and an important negative to be presented in a simple way. Next lecture, inshallah, we'll talk about clinical examination. Thank you.